Okay, hi everyone. It's a real pleasure to introduce the first talk, which will be by Egle Padagate, and she'll be talking about protective factors involved in promoting mental health resilience in a really important group, which is offspring of depressed parents. So over to you, Egle.
Can you hear me okay?
Absolutely, fantastic.
Great. Could I just ask, will we get copies of the slides afterwards?
Yeah, we're gonna, because we're recording, they'll be on the recording, but we will also ask students to provide them as well.
Okay. So hello everyone, my name is Agla and I'm a second-year PhD student at Cardiff University Division of Psychological Medicine and Clinical Neurosciences, and my topic is mental health resilience in adult children of depressed parents. Sorry, yes. Okay. So we know that about 1 in 5 children in the UK lives with a depressed parent, and these children are more likely to develop depression and other mental health problems. However, some of them do not develop mental health difficulties or do so only temporarily, and these individuals may be perceived as demonstrating mental health resilience, a concept that unfortunately still lacks universally accepted definition, but previously it has been defined as special trait, dynamic process, or positive or better than expected mental health outcome. So this mental health resilience observed in individuals at high risk for mental health problems may imply that certain protective factors may buffer parental depression-related effects. However, evidence of these protective factors is limited, and it's unclear if they can sustain good mental health in the long run. So today I'm going to present preliminary results from systematic literature review, focus group, and high-risk cohort analysis. So as you may see, our literature review aimed to identify protective factors for mental health resilience in offspring of depressed parents. And we screened 5 databases and identified nearly 10,000 studies, of which almost half of them were duplicates and had to be removed. But then we screened 5,250 abstracts and 196 full texts. And finally, we included 90 studies in the review. So we're still going through data extraction and quality assessment of these studies. So these results are very preliminary, but overall, we identified more than 80 protective factors from childbirth to adulthood, of which individual, social, and family factors were most studied, while lifestyle, biological, and school factors were least studied. For our focus group, we had 2 aims. First one was to define mental health resilience, and second one to identify most important protective factors that my quantitative analysis could focus on. 5 young adults, 4 females, and 1 male participated in our focus group. They were 24, 30 years old. All of them were adult children of depressed parents, and all of them had mental health problems in the past. So regarding the definition of mental health resilience, young adults thought that resilience could be defined as a process or as a trait, but not as an outcome, since they didn't like the idea that they cannot be or become resilient if they had mental health problems in the past. And they also pointed out the role of self-efficacy, which is believing that you can overcome difficulties in determining if individual would develop resilience or mental health problems after being exposed to adversity. Regarding key protective factors for mental health resilience, as you may see from the illustration on the right, young adults thought that individual factors such as good coping skills, emotional strength, and self-efficacy, and also lifestyle factors such as self-care, good sleep, and exercise are particularly important in adulthood, while external factors such as social network and community support, and also biological factors were considered as less important. So there were many very good points raised during focus group, but overall take-home message could be that resilience starts from within. Regarding high-risk cohort analysis, that we did. So Kolshap and colleagues in 2016 identified a number of child, family, social, and lifestyle protective factors that were associated with mental health resilience in adolescents. So we aim to test if the same protective factors identified in adolescents are still relevant in young adulthood 8 years later. We use the same high-risk cohort as authors did, known as Early Prediction of Adolescent Depression Study, which has 4 assessments over 11-year study periods. And it is a high-risk cohort since 337 parents with recurrent depression and their offspring participated in the study. And we assessed number of protective factors at age 12 and outcomes at age 23. So we used a good mental health definition to derive 4 different mental health outcome groups in our study. So for example, individuals in sustained good mental health group, they did not meet the criteria for psychiatric diagnosis, demonstrated no or low number of depressive and behavioral symptoms, and also did not demonstrate suicidal ideation or self-harm over the whole study period, so overall 4 assessments. Individuals in recovery group, they did not have good mental health as adolescents, but they had good mental health as adults. Adult onset mental health problems group had good mental health during the first 3 assessments in adolescents, but developed mental health problems as adults, and chronic poor mental health never met the criteria and never had good mental health. So we were mostly interested in protective factors for sustained good mental health. So as you may see from the slide, 2016 study examined number of protective factors from different categories such as family, individual, social, and external. And they found that these 5 were associated with sustained mental health in adolescents. So parent positive expressed emotion, co-parent support, self-efficacy, frequent physical exercise, and peer relationship quality. And we looked into the same protective factors, but actually we found that only one of them remained significant, parent positive expressed emotion. So what we found was that if parents were more positive towards their child, this child was almost 3 times more likely to have sustained good mental health as adults. So it may seem that these protective factors identified in adolescents are actually not important in adulthood, but actually it's not the case, because when we looked into when we compared protective factors in all 4 mental health outcome groups, we found that most of them are still relevant, but not for sustained good mental health or recovery groups as we would expect, but for adult onset mental health problems instead. So if you would look into this table, you can see that individuals in adult onset mental health problems group, they score highest on protective factors such as co-parent support, peer relationship quality, and frequent physical exercise compared to all other mental health outcome groups. And these are actually statistically significant. So it could be that these protective factors can actually delay mental health problems in this population. So overall, it seems that protective factors identified in adolescents seem to postpone rather than prevent or help to recover from mental health problems. And we found only limited evidence for external factors having enduring protective effects. It could be that protective factors may only work for a limited time or could be developmental stage specific. And of course, other factors such as individual or partner related factors may be more important in adulthood. But overall, it seems that exposure to protective factors in adolescence does not guarantee good mental health outcomes in adulthood. So next, we plan to do analyses that are less affected by small sample sizes and look into better than expected mental health outcomes using residual scores. And of course, examine other protective factors identified by systematic review and focus groups, such as genetics, physical health, stress response, emotional regulation, mental flexibility, and inhibitory control. And of course, we will try to replicate our results in ALSPAC, another population cohorts using mental health resilience trajectories. And we also aim to look into underlying mechanisms and evidence for causal effects of these protective factors identified. So finally, I would like to thank my supervisors for their guidance and support. Also, Vicky and Jessica for helping me with data access and systematic literature review. And of course, Mental Health Research UK for funding this project. Thank you.
Thanks so much. That's really, that's great. And you're spot on time. Well done.
Thanks.
Yeah, you're seeing there's some claps for you. So questions. Has anybody got a question? Ah, Jennifer has. Thank you.
Thank you. That was really interesting and really clear presentation. I was wondering if you could tell me a bit more about the planned analysis when you were saying about the better than expected scores, so kind of resilience scores. Will you be sort of benchmarking that against some kind of exposure to stress, and how exactly were you thinking of operationalizing that?
Yeah, thank you for your question. Very good question, actually. So we plan to do residual scores analysis. As you said, we will use residual scores for different symptom counts for different conditions. So we plan to look into MDD, mood-related resilience, also behavioral-related resilience using conduct disorder and oppositional deviant disorder symptom counts, and also anxiety-related mental health, anxiety-related resilience using generalized anxiety scores. So we're going to use a risk exposure, which is not stress in our case, but parental depression. So we plan to use parental depression, age at onset, parent depression severity, and family history of depression as predictors, and use these three mentioned symptom counts as outcomes, and then take the residual scores, and we will use these residual scores as outcomes in our analysis. Yes. Did I answer your question? Okay, great.
I don't know if Jen had a follow-up. I know we've got Peter as well with his hand up. Okay, so if we go to Peter next, please.
Yeah, no, brilliant presentation. It was just, I don't think I was reading the table properly, but am I right in thinking then that the group with sustained good mental health had lower protective factors than the group that then had adult onset? And I just wanted to get your views a bit more on why that might be, because I guess on the surface it's kind of a counterintuitive almost. Yeah.
Yes, thank you. Very good question. Actually, we were quite surprised by results as well. So that's, I mean, I don't have answer why would it be, but we thought that maybe these factors might delay. That's why we thought that these factors might delay mental health problems rather than prevent it. And this is interesting because we also did some descriptive analysis for all these four categories, and what we found that actually adult onset group had looked quite good in demographic characteristics, such as their parents were quite educated, they were from higher socioeconomic status, class, and also most of them were still living with a parent as well. So it could be that actually it's compounded by living with a parent, but at the end, it still doesn't explain why they still live with a parent and why they develop mental health problems despite being supported in multiple domains. So this is something that we plan to look into more detail in the future. But maybe you have some ideas.
Not really. I guess, I don't know, I wondered whether there's some other kind of unmeasured difference there, perhaps, that is set. Maybe there's something else going on with that sustained good mental health group that hasn't been picked up by the other protective factors but sets them apart. But that's great, you're looking at it more. I mean, odd findings like that come up, don't they? So if it did kind of, I did wonder about it.
Right, yeah. Really good question. Any other questions? Something that I wondered about is whether you have any patient and public involvement in the study. And through Cardiff, I was just interested that you had your focus group, and I was just thinking it might be really good to stay in touch with them, to as they were quite a small group, but they're probably very interested in your study. I just wondered if you had any involvement of people who are depressed as kind of, you know, advisors around you.
Well, yeah, thank you for your question. Actually, we had the focus group for now, and now we run the analysis, but I think we will get in touch once again when we will try to develop some kind of guidelines or something like that as a result of my PhD.
Great. Juliana.
Thanks, Vanessa. I mean, you picked up the point, and I think that's really good. It probably linked back to just the interest that Peter had in that, what seemed like an unusual finding. I mean, I know I'm talking to the converted here. It's actually quite nice to have people involved all the way through, because they can they can really support you in understanding what those results are. And it could be just an anomaly. It could be, you know, there's just bits that we've not measured, or it could be social desirability in terms of what counts as good mental health. It could be any of those things. And I just think it's really nice for all researchers, myself included, to not always assume that we have to come up with all the answers. Actually, just those who have different types of experiences being involved in that. So I think, yeah, that's what I wanted to add.
Thank you very much. Very good point, actually. Maybe it would be easier to understand results with the help of those who actually experienced it. Very good point. Thank you.
Good. So a tip from us. Thank you so much, Stephen. That's really fantastic. We're going to move on to the next presentation. So I think it's my turn to ask Ellen to introduce her PhD student.
Hi, good morning, everyone. I'm delighted to introduce Catherine Bird, who is a PhD student working with me in the Self-Harm Research Group at the University of Nottingham. And Catherine's undertaking really important work on self-harm, and she's adapting the card sort task for self-harm, which we've developed in our group for young people who are at high risk. And she's asked me to give a content warning this morning that her talk will discuss both self-harm and suicide throughout. And so I'm going to hand over to Catherine.
Thank you, Ellen. Good morning. As Ellen said, my name is Catherine, and I'm a second-year PhD student at the University of Nottingham. I'll give you a brief background of self-harm and suicidality in the high-risk groups, which are the focus of my PhD research, and then I'll discuss the aims of my PhD, what I've achieved so far, and what my next steps are. So self-harm is a significant public health concern, both here in the UK and worldwide. It's particularly prevalent in adolescents, with research indicating around half of adolescents will self-harm at least once. It's got serious impact on people's health, so it reduces both physical and mental health and impacts general well-being. But most worryingly is that self-harm is the most significant predictor of death by suicide, with around half of people who do die by suicide having a history of self-harm. So considering this, reducing self-harm is a key suicide prevention strategy. So some groups are at particularly high risk of self-harm compared to the general population, and these two groups are the focus of my PhD, and they are trans youth and young people with disordered eating. With trans youth, around half of them will engage in self-harm, and they're at increased risk of self-harm compared to their cisgender peers. And cisgender is a person whose birth assigned gender is the same as their gender identity. And similarly, with young people with disordered eating, the comorbidity of those two conditions increases the severity of symptoms, and it also increases suicide risk in young people. Now, previous research has identified many risk factors for self-harm that often precede self-harm, so things like stressful life experiences, depression, maltreatment, and people often experience many risk factors on their pathway to self-harm. But previously they've been researched in isolation as one single factor or with one other factor, but this limits our understanding because it doesn't kind of take into account the multitude of factors that a person experiences as they self-harm. And it also limits the predictive value of risk assessments because, again, focus is placed on one or two risk factors. Little is known about what tips someone from thinking about self-harm to actually engaging in self-harm, and little is understood about why people might engage in alternative behaviours, so things like reading or calling a friend, or it could be detrimental like binge drinking. And my PhD aims to address these gaps in knowledge using the card sort task for self-harm, which we refer to as CATS, which I will do so from now on. And it's developed by a team, including my supervisor, Ellen, and it takes into account the many and varied factors experienced by people who self-harm, and it allows people to systematically describe their own pathway in self-harm. So the picture on the right there is one that I've done myself, just to show you. So along the top, you've got timestamps, so from 6 months prior, right down to I self-harmed and then afterwards. And then underneath, that people are able to place cards that are relevant to their experience. So there are events, thoughts, feelings, behaviours, things like I had an argument with my parent, I felt ignored, I had access to means. There were blank cards if people feel that there's something that isn't explained in the cards already that they can add on. And the aim is that this tool will help both client and clinician to identify meaningful targets for intervention for that person. And previously, it's been used when CATS has been used in research. It's been done in person. So a young person will actually be with a researcher in a room, and they'll have laminated cards, and they'll sort of manually, physically do the card sort task. But this is quite time consuming. It limits the number of participants that can take part and when they can take part. So during my PhD, I'll create an online version of CATS so it can be used, online, and we can reach more participants. Now, as I said, I'm in the second year of my PhD. I'm on a 4-year pathway. So last year was largely a training year. I undertook some compulsory and some chosen modules, which helped me develop existing skills, but also develop new research skills. The compulsory modules taught me some advanced research methods and also skills such as preparing a research paper for publication. And the chosen modules were individual and group interviews and systematic reviews. And I'm already using these methods in my PhD, so they've been really beneficial to me. And alongside those modules last year, I started working on a systematic review of the risk and protective factors for self-harm and suicidality in trans people. So it's well documented that trans people are at increased risk of self-harm. This is because they experience general risk factors like depression and group-specific factors like transphobia, which increases their risk. There's also emerging evidence that protective factors like social support may reduce that self-harm in trans people. But what is clear is that trans people have a very distinct pathway to self-harm. They have unique challenges, and better understanding factors associated with trans harm is essential to identify meaningful targets for intervention that are appropriate for trans people, and also to develop tools which can better capture and assess trans self-harm risk. Historically, trans self-harm has been researched under the wider LGBTQ+ umbrella, but this is problematic considering those unique challenges that they face. So this systematic review aims to synthesize the understanding of the risk and protective factors for self-harm as experienced by trans people. And it also seeks to clarify the relationship between risk and protective factors, including whether protective factors do reduce self-harm risk. And this is really important to better understand how those factors influence the trans self-harm, and identify gaps in our understanding that can be addressed in future research. But it's also important in the development of CATS as a tool, because the cards may need to be changed to ensure they're appropriate to capture the trans self-harm pathway. So 30 papers have been identified and included in the review. And as you can see from the slide, they cover a wide age range. They're from all over the world. So largely there were survey studies, and most of them were conducted in the community. Now this review is still underway, and more findings will be added to this, but so far I've identified 3 key findings. And the first one is that there's significant heterogeneity of risk and protective factors investigated. This makes it really difficult to generalise findings across the trans population. For example, transphobia was found to be significantly associated with self-harm, but that was only investigated by one study. So we can't, from that one study, we can't use it as evidence to apply it to the wider population. Secondly, studies largely investigated general risk and protective factors. So the impact of trans-specific factors like transphobia is less well understood. So again, hard to generalise across the trans population. And finally, there is some indication that protective factors, especially family and social support, does mitigate self-harm risk, but so few studies investigated protective factors. So again, it's really hard to generalize across the trans population. So the ultimate key recommendation at this stage is that more research is needed to reduce the heterogeneity and to investigate trans-specific factors and to investigate protective factors. Alongside the review, I'm also planning a series of focus groups to capture trans views of the existing CATS task as it is. Measures used to investigate trans issues are often cis-centred and they're not validated in trans populations. And this raises questions about how effectively they can capture trans experiences. It's essential to ensure that CATS is appropriate and meaningful to trans people and trans self-harm if it's going to be a useful tool and that's capable of reducing self-harm and improving their health and wellbeing outcomes. So I'm planning a small focus group study to capture their views of CATS. And the aim of the sessions is to explore the meaningfulness and suitability and acceptability of CATS for trans people, and also to explore potential changes to CATS to increase the suitability. I'm currently awaiting ethical approval for this, so as soon as that has been granted, I'll be able to start recruiting for this study. So my next steps are, I'm also going to be doing a focus group study which is exactly the same, but with young people with disordered eating, capture their views of CATS and how it can capture their self-harm. I'm currently writing the ethics application for that. And also the next big step is to begin developing the online version of CATS. Now I have already been doing work on this over the last year. And when I started my PhD, I envisaged that it would be done on a desktop in much the same way as you would do it if you were doing it sort of physically. So I started using software like this, which is basically it's like post-it notes that you can move around online that you can use on your desktop. And I started to develop using Adobe the cards that we could use to insert into this post-it note software. However, I did a bit more reading. And actually, from that, it became apparent that desktop access varies significantly, and a lot of young people actually don't have access to a desktop, or they don't have access frequently or regularly. And also that young people much prefer apps, or an app type access. 95% of teens and young people have their own smartphone. So considering that, it became obvious to me that actually an app version of CATS would be far preferable and far more appropriate for use in young people. So I'll be developing an app version of CATS rather than a desktop version of CATS. And I'm going to begin work in the next couple of weeks with the computer science team at the University of Nottingham to develop the app. And once that has been completed, I'll actually be able to use it for the main study of my PhD, which is to examine the pathways to self-harm and suicide in the high-risk groups using the app version of the CardSort task. So thank you very much.
Brilliant, thank you, Catherine. It looks like you're going to be very busy.
I just have actually one more slide as well. I just wanted to kind of to finish what Ellen said at the beginning, that obviously it's a very sensitive topic, and just if anyone, just reminded that there is help out there if anyone is affected, and there is support if everyone needs it.
Thank you, and thank you for pointing us in the direction of those important charities. If you come off slide share, then it will make it easier for me to see who that got their hand raised. But I know Peter has, so maybe you could go first with a question for Catherine.
Yeah, sorry, me again. I guess just to say, I think it's a really important area of research. I think the whole idea of not just treating LGBTQ people as one group, but thinking more in terms of subgroup is vital. So we've done a little bit of work around self-harming bisexual people, and again, sort of unique challenges and difficulties that don't necessarily run across the kind of wider LGBTQ population. It was more a kind of comment, I guess, than a question, just to say that I think a really key thing here is that we start to think more about how we sort of record gender within studies, because in theory we could easily get a huge sort of shared data set across self-harm research around gender and self-harm, but most people just have male, female or other, and so it really limits our ability, especially when looking at kind of more of a minority group. And so it's certainly something I've been wondering about more recently, and we've kind of played around with different ways of recording that in terms of demographics, and probably still figuring out best way of doing it. But yeah, good to get your thoughts. But I think something around trying to make sure as a kind of community of researchers, we better record this information means there's more opportunity for data sharing and secondary analysis of this kind of stuff. So I'll leave that there, I guess.
Yeah.
Comment on.
Brilliant, thank you. Well, that's a really important point, isn't it, for us as a community? I think Nicola has a question.
Thank you, Vanessa, and thank you, Catherine, for a really interesting talk. I'm a qualitative mental health researcher, so I was particularly interested in hearing about the card sorting task that you're using. I think it's a really excellent way of easily capturing some quite rich ideas, qualitative ideas, and I like the fact that you've got these blanks in it where people can put in stuff that is perhaps more meaningful for them. I think I had a couple of comments around that. I like that you were doing the particular focus on trans people and sort of tailoring and assessing how meaningful or relevant it is for them. But I equally thought you could do a similar process with in fact, all young people, just to sort of check that, you know, the sort of usability, the meaningfulness of it applies to everybody. And I think, I mean, this may be beyond the scope of the PhD. I can see that you're using it as both as a research tool, but I think you're also developing it as a sort of clinical or self-management type intervention. And I wondered if you could say a little bit more, for those of us who don't know, about, you know, what you see as the ways forward for using a card sort task as an intervention, really. I think it's really interesting, but I don't know much about it.
Yeah, it's for my PhD, where it is sort of as a research tool, and it's sort of fairly early-ish stages. So it is primarily a research tool, but I think sort of moving forward, I think it would be really useful as a tool, because young people it can be made really bespoke, so they can really describe their own experience from their perspective. You know, factors that might not be important to me or you or anybody else may be really, really key tipping points to that person. And you know, it would be remiss to ignore them. So I think it could be a really useful tool to be able to, you know, that people can use with you, maybe with a clinician, maybe potentially, you know, get moving forward in years to come on their own, and to be able to identify certain points that are, you know, okay, I recognize that this is when this starts to happen, that is going to be a significant, you know, soon after I will then self-harm, and so I know that now that I need to do something around that time. So as a clinical tool, I think it would be really useful for really identifying those, because you can, you know, obviously you can look at well-known general evidence-based risk factors, which are evidence-based, and they are experienced by many people, things like anxiety and experiencing physical trauma, you know, things like that. But there might be other smaller things that are very individual. So I think it'd be really useful to help people to identify, and also to get to know their own experience better, because you don't always reflect on your own experience until it's much later. But I think it'd be useful for children, well, for young people, to actually be able to use it to reflect and get to know their own journey better.
Thanks, Catherine. We've got 3 more questions. If we could take them quickly, that would be brilliant. So Layla, you're next.
Hi, I was also very interested in the method you were using. It sounded interesting, and I just wondered if you could tell us a bit more about it in terms of how it works, and particularly how you analyze it. You said, I thought you said focus groups, but it's an individual task, is it?
No, so I'm using, so it is a task that someone would do individually. So moving forward, when I've developed the app, somebody would do it as, you know, they would do it individually, but but prior to that stage, the focus groups that I'm planning at the moment are just really to assess, to get the views of the two high-risk groups and what they think of the existing CATS task as it is, and are the concepts meaningful and relevant to those two groups? Are there things that maybe need to be changed slightly? So the focus groups are to ask them their views and to assess the suitability of CATS prior to then developing it to use later on in my PhD.
Brilliant, thank you. And Stephen?
Thank you. First of all, it's a fantastic talk and really, really interesting. So thanks for that. And my question was really following on from Nicola's, and it was just to ask you what your views on were about how doing the CATS task affects sort of thinking, understanding, and the behaviour of young people who take part, who do it, and whether it has some sort of effects on behaviour, and whether those effects might vary depending on whether it's done in person with someone else or online, both potentially positive and negative.
So I think, if I remember correctly, Ella might be able to nod ahead if I'm correct. I think that first of all, talking about self-harm, and actually some research that some colleagues have done about asking young people about taking part in self-harm research. Taking part in self-harm research and talking about self-harm does not increase the likelihood that someone will self-harm. There's some suggesting that there is a cathartic impact of actually taking part in self-harm research. So obviously, it's a sensitive topic, so there are always sort of wellbeing plans and things like that are in place to support people should they become distressed by it. And obviously online that is a bit more difficult because they're online, but yeah, there's certainly not the evidence to suggest that taking part in such research does increase the likelihood that someone will self-harm. I hope that answers your question.
Great. And Juliana, if you've got one quick question, that'd be great.
All right, really quickly, first of all, great presentation, I hear that, but definitely worth looking at the psychosis literature about card sorting, because it's kind of, what people do. And actually often it's the process, it's not even the cards actually, it's the conversations that people have outside that's really important. So, when you said about you can reach more, it's worth kind of thinking about sometimes the disadvantages of that. The second thing is, but there is a whole literature around that, and that's what's really good. And just to kind of pick up on Stephen's stuff in terms of it's about demystifying those issues. If I'm not going to be talking to you about my self-harm, who am I going to be talking to?
Yeah.
I needed to do that. And then the other thing was just going back to Peter's stuff as well, which I think is really important around not all groups have access to this. So really thinking around your focus groups and making sure you're considering the intersectionality, in terms of if you're coming from a Black and minority ethnic group and you're having these issues, which people do, but people don't think you're allowed to do that, making sure that their voices are kind of feeding into that.
Yeah, no, that's
really, really important. Because this is a massive issue. It's an absolute massive issue in our younger groups. And you can see how that differs if you're in the city compared to if you're in different areas or even just in different groups. So this is such a good piece of work.
Thank you. Thanks for your comments as well. It's really useful.
Thank you. Everyone's really engaged with this topic, Catherine. And people, if you've got other questions for Catherine outside, maybe contact her separately. But thank you for your brilliant questions. It's been really fantastic. And I'm now going to pass on to Jennifer to introduce her PhD student.
Hi, so I'm really pleased to be introducing the final speaker of this session, Taryn Hutchinson. So Taryn is in the third year of her PhD, which is kind of scary. It's gone by very quickly, despite the pandemic. So her PhD focuses on adolescent depression, honing in specifically on anhedonia, so trying to understand the role of mental imagery in anhedonia and how it can contribute towards its management. So I think without further ado, I'll let her tell you a bit more about the content of the PhD.
Thank you, Jennifer. So just share my screen. So hi everybody, as Jennifer said, I'm Taryn, and I'll be talking to you today about the intervention that we've developed to target anhedonia in adolescents using positive future imagery. So what I'll be talking about today as a sort of brief overview is just a little bit of a background on adolescent depression and current treatments for depression. As I'm in my third year, I'll give you an update on the progress of my PhD, and then I wanted to spend the rest of my presentation really letting you know what this intervention involves, sort of session by session, what we do, the process we are in of delivering the intervention, and what our next steps are as well. So depression is a common mental health problem, which often begins in adolescence, and if untreated, can lead to sort of more severe mental health outcomes in adulthood. But we know it's really can impact sort of education at the time, our social relationships as well. It's often characterized as extreme negative affect, so but things like feeling low in mood, tearfulness and guilt. I think that's something we often think about when we hear depression. But actually there's another key symptom of depression, which is anhedonia, which is the loss of pleasure and enjoyment of activities that are usually enjoyed. And we can characterize this as an absence of positive affect. And current treatments at the moment, they tend to focus on this idea of decreasing negative affects and making somebody less sad. But what we know is that making someone less sad isn't the same as increasing positive affects, so increasing positive emotions and increasing motivation and enjoyment in things. What we also know about current treatments is they are often involve talking therapies, so verbal techniques using words which focus on sort of the here and the now or the past, and fewer treatments focus on using mental imagery, which sort of a wordy description is representations of sensory information without external input. But what I like to describe mental imagery is kind of seeing with your mind's eye or holding an image within your mind. And we can have mental imagery for sort of past and the future. And why mental imagery is sort of really important is research shows that within depression, young people tend to have really vivid and intrusive memory, negative imagery around memories. And also in adolescence, research shows that young people with depression tend to have more vivid negative imagery of the future. And consistently within adults, there's a sort of a lack of positive future imagery as well. So targeting mental imagery is important because it does have such a clear link with symptoms of depression, but also thinking about the skill of mental imagery versus kind of talking about things. Evidence again shows that our mental imagery is really closely linked to our emotions. So if I ask you to kind of read the word of your favorite food versus actually thinking about your favorite food and what that looks like and imagining it, we tend to get a stronger emotional reaction from imagining it and then reading about it. So just a bit of an update on my PhD so far. So I've been working on a narrative review to identify treatments that target increasing positive affects, so increasing positive emotions within depression, and focusing, often a lot of these interventions contain lots of different skills. So trying to tease apart what the kind of mechanisms are and active ingredients in increasing positive emotions, and kind of using the literature to really guide kind of the intervention that we've developed. As a lot of people's research has been impacted by the COVID pandemic, because my project, which I'll go on to explain, is based in schools, we obviously, with all the lockdowns, were unable to get into schools. So we were really fortunate to actually use that time, and Mental Health Research UK have been really supportive in allowing us to deviate slightly and actually conduct a survey, a longitudinal survey. So we had a survey with over 2,000 young people that took part in the end, and we asked them to fill it in sort of every 2 weeks for up to 8 weeks. And we had a variety of measures, but particularly around my PhD, we had symptom measures of both depression, so sort of low mood and anhedonia, and questions around mental imagery. And we're currently in the process of writing a paper about our kind of first set of findings around mental imagery and depression. And now with things starting to open up a little bit, we've been really fortunate to get into a school and start delivering the intervention, which is what I wanted to spend sort of the next part of the presentation talking to you about. So our intervention is called Imagine PA. The PA stands for positive affect, and it aims to target anhedonia and depression by increasing positive affect, these positive emotions. Imagine PA has been developed from Imagine, which is an intervention by my supervisors, Jennifer Lau and Victoria Pyle, which focuses on using mental imagery to target and memories specifically to target treating depression, and using techniques such as memory specificity training and imagery rescripting for negative memories. And we've adapted that intervention to focus particularly on upregulating positive affect, which I'll explain again the techniques we use to do that. It's a school-based intervention, so we're targeting 16 to 19-year-olds. And a key kind of, I suppose, difference with Imagine is we've got a bit more kind of positive future imagery generation as a means of upregulating positive affect. So it's a 4-session intervention which we're delivering face-to-face. So in our first session, we really focus on memories and the ideas of how our memories can link to our thoughts, feelings, and behaviours. And we introduce the idea of positive imagery generation, asking them to imagine a memory, a positive memory that they've had, and seeing how that links to their sort of thoughts, feelings, and behaviours. In the second session, this is where we begin to focus on the future, particularly the near future, say something that they're looking forward to in the next 7 days. So the example I've given here is that maybe it's my birthday on the weekend. So we ask them to generate an image of something they're looking forward to in high levels of detail using all their different senses, sort of what they can see, smell, taste, touch. And what we notice during that imagery generation is that we might have things called dampening thoughts, which might interfere with how positive this image is. So for example, I might have the thought that nobody's going to come to my birthday party. We know as well that we can get quite self-critical thoughts, especially when we're thinking about the future, which can interfere with positive feelings and reduce our mood. So again, in this session, we really focus on introducing this idea of self-compassion and using imagery to do so. So I'm asking them to imagine somebody who's compassionate in their lives and what they might say if they knew what kind of self-critical thoughts they were having. In the third session, we again focus on positive future imagery, but for a more long-term goal. So for example, here maybe getting their university degree. We get them to imagine what the ultimate goal is and imagine achieving that goal, and then think about the steps along the way to that goal and thinking about maybe what will be good about that journey, but also what might be tough about that journey. And lastly, in our fourth session, it's a summary session to think about the things that they've learned in the sessions, but we also focus on values. So family, friends, hobbies, education, employment might be some examples of values. And we think about how these values, what's important to us, link with memories, but also what we want to achieve in the future. And as I said, we kind of summarize the skills from the session and use that as a bit of a plan for the future and how to kind of continue practicing skills. We also have some homework tasks to help practice these skills, so around making memory specific and detailed, and also asking them to notice positive events that have happened each day and what that says about them, to kind of increase that evidence, really, especially around being self-compassionate, having evidence of positive things that you've done. So in terms of our progress so far, so we first of all delivered a presentation to a school of a sixth form of 420 young people, and we are in that presentation, it was a more general presentation on kind of well-being, but also about the study and kind of letting them know about if they were interested in taking part. From that, 21 students took part in our screen questionnaire using the mood and feelings questionnaire, and from that 15 were invited to an assessment session. 9 young people took part in that assessment session, and 7 young people met our eligibility criteria, and so far 7 young people have started the intervention as well. So in terms of what the next steps are, so we really hope to finish the case series shortly and publish what we find from the case series. But also the next steps, we had originally planned to do a randomized control trial to see the effectiveness of the intervention, but unfortunately with the pandemic and the timelines, we've had to adapt this somewhat. But it's quite exciting actually that what we've decided to do instead is a qualitative survey where we get a much more in-depth feedback from young people's experiences of the intervention. So we're particularly interested in sort of acceptability around the intervention. So what worked, what didn't work so well, things like feedback around it being in a school setting. And we recently attended the Adolescent Mental Health Advisory Group to get feedback on whether they thought the types of questions we were asking were appropriate, and if they wanted us to, they thought actually we could be asking anything else. And a really key part of their feedback was actually about asking young people, did this intervention meet their expectations? So we hope to kind of implement their feedback for our topic guide moving forward. But thank you so much for listening today. And if you've got any questions, please feel free to ask now, or that's my email on the screen. But a big thank you to Mental Health Research, as always, for funding this research, and also to my supervisors, Jennifer Lau and Victoria Powell, and also my colleague Laura Riddleston for her support during the project.
Brilliant. Thank you, Taryn. Fantastic presentation.
Thank you.
I think the room will close automatically in about 3 minutes. So we've got time for a couple of quick questions, and I'm sorry for my poor timekeeping, but I'm sure somebody has got a question for Taryn. I'm gonna look on my screen. Peter.
No, I feel bad that I've asked questions to all of them.
Fine.
I'll just email this time. I won't bother to send. I was just going to say it's really interesting to hear about the positive imagery stuff, because we're doing some work of sort of a similar intervention, really. So looking at positive imagery around previous memories as a way to generate positive effects. We've been looking at it more in the context of suicide prevention, but we've just started the end of last year. We've got a clinical trial running looking at that as an intervention for university students. But I just think it'd be good to get in touch at some point and find out more. You know, find out more about the intervention you guys are using, because it sounds like there's a lot of parallels. I'd be keen to find out more about it. So I'll fire you an email at some point, but that was it.
That'd be brilliant.
Fantastic. Any other questions? I was interested, I know we met last week and you did the practice presentation. You were going to go to your young people's group. I wondered whether you could tell us anything about how young people are feeding in, particularly into this final phase of the study around the focus groups, and what tips they gave you.
Yeah, absolutely. It was a great experience, and in terms of we actually did a positive future imagery generation, and getting their feedback again on that was really great to hear that they will engage with it. And in terms of the next steps around the qualitative study and the kind of questions for our topic guide, I think they were just really encouraged around thinking about, obviously we as researchers have interests and things that we want to know, so as I mentioned around acceptability, but also kind of what mechanisms are really working, or more broadly, where do they anticipate change, therapeutic change occurring. But kind of we wanted to know what young people are interested in and on what they think are important, and certainly around kind of, did it meet expectations of the therapy, did they sort of, what they, I suppose even how to ask what they find useful, and using their language as well was really, really helpful.
Brilliant, thank you. And I can see we've got a question from Emma and then Juliana.
Hi, that's really interesting, thank you. I just wondered what your experiences had been like with getting ethical approval for the project that you're doing.
Yeah, I think certainly having, because our project was adapted from Imagine, we had sort of some, or in terms of the background and kind of sort of justifications for doing the project, but also in terms of we also had to think sensitively, because we're delivering this in a school, so around identifying risk and following risk protocols, particularly around safeguarding and things like that. That was quite a big I suppose, not necessarily challenge, because I think, especially because my colleague had delivered a similar project already, we had some ideas of how to manage this and how to go about this. But certainly in terms of when you're kind of doing any sort of mental health research within a school setting and thinking about how following what the school protocols are and ensuring you stick to that, that was probably the main thing that we had to really kind of focus on.
Thank you. Yeah, I was just curious because I also do a lot of research in schools and sometimes face a bit of a battle with ethics. So I was just wondering what's going on.
Brilliant. That sounds like it was smoother than it might have been. Juliana.
Thank you. Taryn, I just wonder if you could tell us just a tiny bit more in terms of this, the type of schools that you're going into, or that kind of are involved in this, without names sort of thing.
Yeah, sure. So we've been pretty, I suppose, especially because it was quite challenging with the pandemic to engage with schools. We were pretty much taking an approach of kind of contacting as many schools as possible. So when I first started my PhD, contacting schools, particularly around the area that I was based in, because of kind of traveling and maximizing the amount of sessions we can deliver versus traveling across London to reach schools. The school we're working with at the moment have my supervisor Jennifer actually has worked with the school before, so they're quite familiar with kind of research and also kind of well-being within the school, and so I think like we have contacted lots of different schools and various schools. So at the moment we're kind of more based in sort of East London, but actually kind of we'd engaged with schools previously in Lewisham, and a period of time we tried to develop the intervention online and engage with a school in Manchester. So I suppose we've tried to contact a variety of different schools, and the biggest hurdle, I guess, is that a lot of the schools are really interested, but they're very busy, and trying to slot in a research project alongside everything else they have to do gets tricky sometimes. So it's kind of the school that has the kind of capacity to take us on that we tend to then work with.
Yeah, I mean, it wasn't sorry if it's kind of come over, it wasn't a trick question, it's more just to kind of highlight your good work insofar as I think if people aren't doing that work in schools, it's really hard. And schools since the pandemic have been a sort of one-stop shop for dealing with so many different things actually, so and have really been chomping at the bits to kind of have anything that might support the well-being of their students. So I think it's more a reflection on you and your hard work to kind of get those numbers in. So yeah,
brilliant, thank you for that feedback.
Brilliant. And I wondered, just building on that, what next? Will you try, or will the group try and do a bigger study on the basis of your findings? Are there plans for a stage 2?
That's a good question, actually. So ultimately, originally we had hoped, especially the kind of final part of my PhD would be around kind of doing that randomized control trial to kind of see the effectiveness of the intervention. I know my colleague Victoria Parr's got a fellowship to continue working with Imagine with young people and depression. So yeah, it'd certainly be interesting to see kind of where we could take it next and so forth.
Brilliant. Any final questions? I think it's difficult on the timing. I think we have a minute. So is there any other reflections or feedback that we have for Taryn in her final year, having pushed through COVID, adapted her study and got into schools?
Apart from saying it was excellent, all of them.
Yeah, they're all really, really good presentations. Obviously, you know, the focus on children and young people, it's just such an important focus. I suppose just a shout out, I don't know if any of you are aware that the Department of Health have got a consultation out at the moment for their next 10-year plan for mental health. I'll put the link in the chat actually, but it's worth kind of promoting it among your research teams and in your networks. It's always difficult to know whether these kind of things, these consultations are pointless or important, but there is a really key part of it that's about children and young people, older people's mental health, adults and at-risk groups, and the consultation is open till July. And I suppose we're trying to encourage as many people to kind of put sort of focused views forward into it. And an interesting part of that is there are specific questions about research. What are the key research questions to improve the mental health of young people, of older people, of adults of working age, and at-risk groups? So if we get our thinking caps on and feed some questions into that consultation process, we might find more money flows towards mental health research in the future.